We call social problems such as the opioid epidemic wicked because they are vicious like a circle, tricky like a leprechaun, or aggressive like a lion. These problems are wicked because they're never solved. They're only resolved over and over again.
Because of the opioid epidemic across the country, the federal government announced the 21st Century Cures Act funding, which Ohio was one of those recipients. We were really excited about this opportunity to truly look at the opioid problem as a wicked problem and utilize those funds in an innovative way that we just haven't had the ability to do so previously. With those funds, there came a set of specific goals related to the reduction in OUD deaths as a result of an increased collaboration between prevention, treatment, and recovery supports, as well as increased access to medication-assisted treatment. As we began thinking about the approaches and frameworks available, we really looked at collective impact as an approach to hone in on those critical backbone organizations and communities that have the authorizing environment to bring key players to the table to develop those shared measures and outcomes so everybody's working towards the same goal without losing their respected areas of expertise. All the work has to continue, but without that strong backbone organization, it's really difficult to address these wicked problems. And we know that community trauma is a really wicked problem within Ohio that needed to be addressed as part of this work. So because of that, we were able to release funding to 2 cohorts of communities across the state to engage in this opportunity with us. These communities were a really diverse group from various locations, bringing lots of expertise and knowledge to the table that really helped us guide and build this project over the course of the funding period. So to move this work forward and to make it happen, we knew we really needed strong partnerships. So we were able to bring on board Ohio University's Voinovich School of Leadership and Public Affairs, the Pacific Institute for Research and Evaluation, as well as Prevention Institute, who all brought different perspectives, backgrounds, and expertise to the project.
But a community of practice is rooted in that idea that communities learn best from one another. So if we unpack that statement, what does that mean? When we say communities learn best from one another, what we're really saying is that each community brings wisdom to the table. Each community brings that experience to the table of their local environment. And collectively, we have that collective wisdom that helps us understand these frameworks better, but also understand how opiates are affecting or impacting Ohio.
The first step when this project began was to understand the scope of what was going to be needed for us to impact the opioid epidemic across Ohio and in our CCM4C communities. This was an initial step that helped us really begin to develop that common agenda. Our second step was to create our theory of change. We specified what we hoped to do, who would do it, how we would do it, the frameworks we would use, and the outcomes that we hope to achieve.
So collective impact was first introduced in 2011 in a journal article by Connie and Kramer. It includes 5 key components: a common agenda, shared progress measures, continuous communication, mutually reinforcing activities, and finally a backbone organization to act as the facilitator and the system integrator and to keep everyone on the path moving forward.
The reality is collective impact is a planning process that requires rating and integrating of multiple partners. So it's more than just, I need partners to help me get this plan done. It's we need to come together and be there every step of the way. So it's not the barter system, you do this for me, I do this for you. It's really coming together as a community and saying we're all in on this particular issue.
One of the keys to success is that everyone understands the strategy we're going to follow and what role each person will play. So the common agenda for our community consists of our strategic plan maps, which give a picture of what our strategy will be, hence the name. Our theory of change, which helps to encompass the rationale and again the key players, as well as our ecosystem, which highlights our key players and potential players.
The collective impact process allowed us to identify those individuals, those organizations that were already having community activities or services, and allowing us to fit that into our strategic plan. But also it allowed us to see where the gaps were and then be able to develop new and novel activities that might help fill in those gaps. So there were already events in place, there were already activities happening in our community that contributed to solving our wicked problem.
The first step in addressing a wicked problem is actually framing the problem. In order to describe a wicked problem, you actually need to consider possible ideas for solving it. And by solving it, we don't mean specific detailed strategies. Instead, we mean creating an approach to work on the issue. For example, with the opioid epidemic, we knew the solution had to include prevention, supply reduction, demand reduction, and harm reduction. We knew it had to include treatment, and we knew it had to include recovery.
There's another property of wicked problems. And that other property is that every wicked problem can be considered a symptom of another wicked problem. So when you think about opioid use, think about your own community. What else is going on in your community that is contributing to the opioid epidemic? A lot of it is trauma. So now we have the double wicked problem because you're dealing with a wicked problem of opioid use, and then all of a sudden you're throwing another wicked problem in there.
And what we found is that prevention, treatment, and recovery supports are necessary, but they are not sufficient.
Because if we don't dig one level deeper and address the social determinants of health, we aren't going to get to that core issue that's driving opioid use.
And then once we were able to ask those questions, it then allowed us to go a little bit more broadly. And using that lens of community trauma helped us to kind of consider a fuller picture of the community and look at those things that might be impacting the epidemic beyond what we usually think about. So it opened up opportunities to start thinking about economic opportunity and living wages or housing or social connections, which I know became such a huge issue for so many folks that are part of the CCM4C project.
Looking at how wicked problems exist in our community, how to help our community break that cycle of unhealthy community deterioration, that we understand the different levels of trauma and what type of trauma exists in our community.
We can take a look at housing a little closer. In Lucas County, we see boarded up properties for drug reads. We see abandoned properties turned into shooting galleries. We see full shelters and homeless camps, and we see long waiting lists for public housing assistance and the demand for recovered housing. So what do? We acknowledge how these potential partners have been impacted by the opioid crisis. And from them, we start a conversation and we gather their data, we get their perspective, their strengths, their expertise, and their resources, and we have an opportunity to form a unique and creative partnership. We engage them to form strategies that will end up being mutually beneficial all while working on our common agenda.
First is keeping in mind some other community planning processes that might be happening. Many local health departments are working on community health improvement plans. Hospitals work on community health assessments. So keeping those in mind and working with those other assessment efforts can help reduce redundancy and help to ensure that your plan is aligned with other things that are going on in the community.
We then brainstormed the causal factors and then asked that important question, but why here? To brainstorm our more specific root causes. So the strategic map also addresses those measurable goals that are not only short-term, but mid-term, and then the overall goal.
Once we identified those key data indicators that we were going to follow on the different strategic plan maps, it really has helped us to not only know, but also share what the doing is actually doing. And that's been a big help through this process.
We have developed strategies and have been fortunate enough to implement some of those in our community, and being able to pull the business leadership and maybe social services, the leadership there, and our prevention team has really worked, and it's been an exciting opportunity. So not only recognizing leadership in the community, we are building leaders.
And if we do that, we hope this initiative has created conditions in Ohio for communities to, 1, increase their efforts that are focused on a common agenda, 2, implement strategies to mobilize communities, to show communities you care about them and the issue of opiate use disorder, address the trauma that causes opioid use but also is exacerbated by opioid use, and finally, developing those strategic plans that are cohesive and across the continuum of care instead of prevention's doing this, treatment's doing that, and recovery's doing this. We all have the same goal, so let's get us all on the same roadmap.
The other great outcome of the Collective Impact Initiative is that we found a framework that we can instill in communities to support them as they address their most pressing substance abuse and mental health issues at the local level. We know that communities are likely to get to the outcomes they need or want when they work within a more coordinated and comprehensive approach.